While we are discussing the adrenal gland, we've already gone through the secretions, the excessive secretions of the cortisol, and what are the effects of these excessive secretions of the cortisol in the blood or in the serum levels. It's going to be a clinical picture which is basically characterized by the buffalo hump, by the obesity, by the hirsutism, by the moon face in that particular patient. And then the psychiatric symptoms in such a case would basically include the cases of mania or hypomania. And on the other hand, these patients are also going to suffer from anxiety and panic. So this is a typical clinical picture of a patient who's suffering from excessive cortisol in his or her blood. On the other hand, we have the Addison's disease, where there's basically an adrenal insufficiency that is observed in these patients. So what are the neuropsychiatric complications in a case of Addison's disease or in a case where there are a decreased level of cortisol in the blood? That will be the main highlight of this section over here. We're going to go through the adrenal insufficiency. How do you basically define this Addison's disease is again very important, because again the laboratory investigations are very important in this particular case of Addison's disease. We're going to measure the cortisol levels, and then there is going to be a diurnal variation of the cortisol level that is also going to be measured in these individuals who are suffering from Addison's. On the other hand, either they're suffering from Cushing's disease or they're suffering from the Addison's disease. Then we're also going to discuss hyperpituitarism. So hyperpituitarism is basically also known as a condition, which is a clinical condition arises due to this hyperpituitarism, which is known as acromegaly. And we're going to discuss what are the causative factors for this hyperpituitarism and what are the neuropsychiatric manifestations that are associated with this hyperpituitarism that will be discussed over here in this very fourth section. So while we are discussing the Addison's disease, the deficiencies in the glucocorticoids or the mineralocorticoids are the particular features of the Addison's disease. There are going to be the mild disturbances in the mood and the motivation, as well as in the behavior of the individual. So there are going to be phases of mania and depression, or either there are going to be phases of hypomania that are observed in these individuals. On the other hand, they are going to be the least motivated people. Mostly depression is the the clinical picture that is observed in these individuals. There's going to be a behavioral problem even observed in these individuals. Psychosis and extensive cognitive changes, that is basically delirium, is observed in these individuals. Basically, delirium is the confusional delirium, and dementia is the confusional state that is observed in these individuals as well. Then we're going to have the catatonia and self-mutilation. Self-mutilation, or which is also known as the deliberate self-harm, are more rarely seen in these individuals who are suffering from the Addison's disease. Then when we talk about the adrenal insufficiency, they're treated by replacing the hydrocortisone. Obviously, there is an insufficiency of this mineralocorticoids and the glucocorticoids that can be treated by the replacement therapy. Then we can have the severe affective disorders in these individuals. A risk for developing the elevated mood symptoms in these individuals is again very important in context of receiving the hormone replacement therapy that is observed in these individuals. So when we have a look at this context of receiving a hormone replacement therapy, these are basically the treatment guidelines that can be given for these people who are basically suffering from the decreased levels of the cortisol in their blood, or either they are suffering from the adrenal insufficiency. And the elevated mood symptoms are sometimes seen after this replacement therapy. Previously, they were in a depressive phase, and after the therapy is given, there can be the phases of mania or the mood elation that is quite frequently observed in these individuals. When we have a look at the hyperpituitarism, we have the prolactinomas, and then we have the amenorrheas. So usually you'll have a female patient who is presenting to you with this amenorrhea, these complaints of amenorrhea. Or you will have a male patient who is suffering from prolactinomas or galactorrhea. So usually you're going to suspect this hyperpituitarism in these patients. This galactorrhea and gynecomastia is observed in the male patients. There's going to be a decreased libido and sexual dysfunction. The drugs associated with inducing hyperprolactinemia is again very important. Then we have the antipsychotics that are usually given in such a case, phenothiazines and butyrofenones and risperidone. So usually the antipsychotics that are given along for the hyperpituitarism for patients who are suffering from hyperpituitarism are phenothiazines, butyrofenones and risperidone. The antidepressants that are usually given are the amitriptyline, imipramine and amoxicillin. The dopamine receptor antagonists that are usually given are the metclopramide. Then we have domperidone and sulpride. So these are the three major groups of antipsychotics, or the three major groups or to control the neuropsychiatric manifestations in the hyperpituitarism, ranging from the antidepressants, antipsychotics and the dopamine receptor antagonists in these individuals. The treatment modalities would include risperidone. The greatest capacity for stimulating the prolactin secretion in these individuals is again very important. The common clinical dilemma that is associated with this hyperpituitarism phenomena is the psychotic patients are usually on the neuroleptic drugs who develop the menstrual dysfunctioning. Then these neuroleptic drugs have the side effects for the galactorrhea or the gynecomastia in the males, and they're also sometimes associated with the elevated serum prolactin concentrations. So whenever you are giving these treatment modalities, you should know that these neuroleptic drugs such as risperidone, they have their own side effects and they have to be managed. These side effects even, they have to be managed in their own way. So when we have a look at the range of the antipsychotic treatments that are available, in which basically we can choose for these patients who are suffering from hyperpituitarism, they can switch to the alternative antipsychotics if risperidone is having the most side effects. The quetiapine and olanzapine is one of the drug of choice. This is less likely to exacerbate the hyperprolactinemia. The use of aripiprazole, the advantages are there's a decreased prolactin due to the mixed dopaminergic antagonism or agonism in these individuals. The use of the dopamine agonist, which is also the bromocriptine or carbagrelin. So these are the drugs, the dopamine agonists that can be used in these individuals. These are the atypical antipsychotics that are sometimes used. That basically includes the potentially risky individuals, and then they can lead to the worsened psychotic symptoms. So they are not quite commonly used, this bromocriptine and carbagrelin, unless proven otherwise, despite the patients remaining on an antipsychotic treatment. So this is basically a range of drugs that can be used, ranging from risperidone, quetiapine, olanzapine, aripiprazole, and dopamine agonists, depending upon the different individuals and depending upon the effects or the side effects that are produced in the different individuals. So in this section, basically, we summarize these two conditions known as Addison's disease and hyperpituitarism, and what are the basic neuropsychiatric complications that are associated with these two conditions. So that is the end of this section. Thank you for watching sqadia.com.